Good evening and welcome to IHW Council's special web series on women's health, START, supporting treatment in assisted reproductive therapy. I'm Anisha Nair Thavan and you are watching our exclusive show on women's health supported by Bharat Serums and vaccines under its public awareness initiative. We are all watching the COVID-19 second wave unfurl in India now, hoping and praying that it ends sooner than later, a year after its first outbreak. This is just a reminder that we cannot put our guards down, that we have to ensure masking, washing hands, and social distancing. This is also a reminder to put our health before anything else. The arrival of the vaccine, the start of the inoculation process, and the lessons from last year have brought hope to millions who want to stay safe and bring about a semblance of their pre-corona days. But there are many others who find themselves in despair as some of their dreams have suffered a setback because of the many restrictions of the lockdown and the fear of COVID-19. I'm talking about couples who dream about starting their family but are unable to do so because of infertility. Infertility over the years has emerged as one of the most common health issues that many young couples are facing. According to the Indian Society of Assisted Reproduction, infertility currently affects about 10 to 14% of the Indian population. The scenario is worse in urban areas where one out of every six couples is impacted in big cities. Now, our show is special as we are going to discuss all aspects related to fertility and IVF treatment. Bharat Serum and Vaccines Project START is an initiative that aims at providing support to couples beyond medicines with initiatives like microfinancing the treatment and counseling. Project START encourages couples to stay on course for the IVF treatment to achieve the goal of parenthood. Today, we'll be talking about Blastocyst transfers in IVF. On our show today, we have an expert joining us to help answer all your queries. Please welcome Dr. R G Patel, Gynaecologist, Infertility, IVF and ART Specialist, and Director, Sunflower Women's Hospital, Ahmedabad. Welcome to the show, Dr. Patel.
Good evening to everybody. Anisha ji, welcome.
Before I begin the conversation, I would like to request all our online viewers to keep sending us your questions to the comment box with this post. We will try to answer as many questions as we can over the next 30 minutes. And this is your opportunity to ask questions from an expert. So don't let this opportunity go away. Do like and comment with your feedback and do share this show on the walls of your friends if you think they will also benefit from all that we will be discussing today. And just a reminder, if you are going to be sending us questions, try to put in as many details as you can, your age, your specific medical condition. Please put in all those details so that Dr. Patel can answer all those questions to the best of his ability. Okay, Dr. Patel, let's begin. Now, we're talking about blastocyst transfer during an IVF. Now, what is blastocyst transfer versus an embryo transfer?
Yeah, thanks. We know day by day the infertility increasing, and the treatment when routine treatment like medicine, IUI or laparoscopy fail, then IVF will be the better option. In IVF, again we need good result, good outcome with minimized risk. Now IVF result is increasing, cost almost remains stable since last 5 years because of better technology, better understanding of the physiology, better IVF lab work, better culture media, better medicine, and the risk of the IVF is nowadays little decrease. At the same time, the result and outcome, the pregnancy rate is increase. Because of this, we need to understand the result, and the result is depend on the quality of embryo. The embryo we produce by the egg and sperm fertilization in the IVF lab in a petri disease in a culture media. The embryo will form, and depending on the day, maybe day 2, maybe day 3 or day 5. The day 5 embryo is known as blastocyst embryo, and the blastocyst transfer will give good outcome. in comparison to the day 3 or day 5.
Right. Dr. Patel, conventional wisdom a few years ago used to be that IVF is nearly playing God. Okay, you're playing God and you're producing a baby in a petri dish. But most of the fertility specialists said that there's a limit to what even we can do as God. So we don't want to risk how the embryo develops. Let's transfer the embryo day 3. After the transfer on day 3, the best bet of the embryo growing is in the uterus, which is its natural home. So, is it more risky to wait till day 5 for the embryo to develop and then transfer it? Does it become too late?
Yeah, definitely uterus is a natural worm. If you transfer day 3, we are safe. If you see the data, the transfer on day 3 or blastocyst transfer, the implantation rate and pregnancy rate is increased with the day 5 embryo, because this is a blastocyst to produce is not fit for everybody. Those who have good prognosis, good eggs, good sperm, on day 3, if embryo is more and good quality of blastomere, we can go for the blastocyst culture. And for blastocyst culture, we need good embryologist, good embryology lab, good culture setting, good incubators, and quality management. Then we can produce the day 5 blastocyst. What is the risk to produce day 5? Sometime it, if you have less embryo, not good quality day 3 embryo, then you may held up an arrest on day 4. So there may not be any embryo on day 5. So that is the risk of to produce the blastocyst. But if good prognosis patient, good number of day 3 embryo, maybe 5, 6, good quality of blastomere, day 3 embryo having 8 blastomere, then you are enough confidence, you are even experience, then we can produce day 5 embryo. Day 5 embryo, on day 3, up to day 3, there is a maternal genomic production, but after day 3, up to day 4 or day 5, there is a embryonic genomic will evaluate, and the quality of embryo will be better if we choose the best one, grade 1 embryo, that is known as 4AA, and if you transfer day 5 embryo, the implantation will be good. What is the beauty of day 5? So we have to minimize the number of embryo to avoid the twin pregnancy. We know there is a lots of problem of twin pregnancy. Because of twin pregnancy, there is a chance to have a premature baby. And that premature baby again will load on the NICU, neonatal care unit. And patient may develop hypertension, may develop diabetic, and the risk of prematurity is major in case of twin pregnancy. So
Right.
what we have to balance is, again we need pregnancy, and at the same time we need to avoid the twin pregnancy. That can be produced only with the good quality culture media, good experienced embryologist, and good blastocyst.
So, Dr. Patel, in your mind, how is the success rate of blastocyst transfers improved over a day 3 embryo transfer? Is it the quality alone of the eggs? Is it the type of lab that you have? Because it's not all labs are able to produce or grow the embryo till day 5. So, what really matters the most in the success rate, improvement in the success rate of a blastocyst transfer?
Yeah, on a blastocyst transfer, if you transfer single embryo, the success rate of pregnancy is around 65%. If you transfer two blastocysts, then success rate may be 75%.
All right.
How?
But then
Yes.
what is the most important factor? The age of the woman, the quality of the eggs, or
Yes.
the ability
All
of the
depend the
embryologist,
success.
or the lab? What is the most critical, point that
Yeah,
determines the success?
good. We need good result. For the good result, we need blessed quality embryo, and
Mhm.
the quality of endometrium, quality of uterus also. Soil and seed both are important. Here we need good embryo, and if we have good quality embryo, and if it is day 5 embryo or blastocyst embryo, then implantation will be better, outcome will be better. But that not possible in all cases. Those who are old age having less egg, less embryo formation on day 3, and some sperm problem also, then day 3 is we can think to transfer day 3 embryo if we are afraid of, if we may arrest at day 4 and there may not be available any blastocyst on day 5. So that by experience, by number of embryo on day 3, quality of day 3 embryo, your lab setup, your experience of the embryologist can take decision about to transfer on day 3 or day 5. But by by data and our own experience is also same, the day 5 blastocyst will give good outcome.
All right. So you just clarified for everybody, Dr. Patel, that blastocyst transfer doesn't happen in every IVF case. Not all women's, eggs will reach blastocyst stage in a petri dish. But we've already started getting a few questions from viewers who are watching this on Facebook. So one Facebook user is asking, when is blastocyst transfer recommended?
When there is a high risk, we need good result. For the good result, we have to prepare the good uterus and endometrium. If good uterus and endometrium is there, we need single embryo transfer. And after single embryo transfer, we need good implantation rate, good pregnancy outcome. So in a good prognosis, like young, having good uterus, good endometrium, we can produce blastocyst. And after a single embryo transfer, the implantation rate will be good and pregnancy rate will be good. So because of single pregnancy, during pregnancy, there is a less chance of prematurity and less chance for the hypertension. So in a good quality uterus, young, having good quality egg, good quality sperm, good embryo formation on day 3, we can go for the day 5 and we can transfer single embryo and outcome will be better. Those who have 2 or 3 IVF fail and poor prognosis, we can transfer 2 embryo. Otherwise, single embryo will be give good result.
Right. Dr. Patel, for someone who has age by their side or have good quality eggs, do blastocysts also freeze well, like day 3 embryos? Say, one woman has made a lot of good eggs and she has multiple blastocysts, who have gone till, day 5. And of course, you don't want to transfer multiple blastocysts because, then it results in high risk pregnancy. So can you freeze blastocysts? Are they as good, as effective as a day 3 embryo? And can they be used later?
Yes, those who are normally we transfer 1 or 2 embryo on day 3 or day 5. The remaining we will assess, which is grade 1 and good quality embryo. We always do freeze it for the future use. After freezing, we can use after even 1 month, 2 month, 1 year, 3 year, even 5 year. So that embryo we can preserve for a long time. If suppose patient having success in first trial and the same embryo we can do cryo for 3 years and this patient will come again after 3 years and this previously preserved embryo we can transfer after 3 years and the success rate is good. So that embryo, extra embryo we can do preserve. Suppose first trial fail, then the ready-made embryo we can throw it and transfer in the second month.
All right. Dr. Patel, we started getting more questions, and a Facebook user is asking, my wife has abnormal shape of uterus and has repeated abortions. What treatment would you suggest to a woman having an abnormal uterus shape?
Yeah, the uterus is the main reason for the many abortion. What we need to do is mid-cycle, that is day 11, 12 or 13, we have to do 4D sonography to see the what exactly type of shape. There is maybe unicornate uterus, bicornate uterus, maybe subseptate uterus. So depending on the problem, we can correct by the laparoscopy or by hysteroscopy. So before going to second trial, if possible, we can correct it by the laparoscopy guided hysteroscopy. If even though it's not success, then we have to understand what is the other problem. So even in repeated pregnancy loss, we have to find out the other reason like genetics, hormones, infection, quality of uterus, any sperm problem. Whatever the problem, we have to find it out, correct it, make the healthy atmosphere, then try again in a healthy atmosphere. And after pregnancy, you have to need to give more support in form of even progesterone. And if uterine problem, we can we have to assess the cervical length during pregnancy. If needed, we can do os tightening and we can give some supportive treatment, maybe tocolytic, maybe progesterone.
पर आप ये कह रहे हो डॉक्टर पटेल कि अगर यूट्रस की शेप में प्रॉब्लम है तो सर्जिकली ये रिपेयर या ठीक हो सकता है.
Yes, if it is correctable reason, we can correct with the surgically with the hysteroscope under the guidance of laparoscopy.
Okay. We have another question. Facebook user is saying, hello, I'm 39 years old. I've been trying to conceive for the last 6 to 7 years. I have less egg formation. I have thyroid and high BP problem. My left fallopian tube is blocked. I have an 8-year-old daughter from a normal pregnancy. Please suggest.
Yeah, because of some less embryo, less ovarian reserve, so we have to assess the exact what type of ovarian reserve is less, and at the same time they have blood pressure problem. We have to see the assessment of the by sonography. What is the AFC? What is the uterus? And what is the situation of the sperm also? As a whole, where there is a problem, we have to correct it.
Mm-hmm.
Because of age is 39 and ovarian reserve is less, we have to give some pre-treatment in form of testosterone or DHES or coenzyme Q, and we have to manage the hypertension by diet control, exercise, yoga, meditation. We have to investigate anti-nuclear antibody, homocysteine, or any obesity problem. We have to correct the thyroid properly, and whatever the reason, we have to investigate in a detail. We have to correct as much as possible. Because her age, we can allow them non-natural pregnancy, but it's not to take too many times. Then if she conceive within 2 or 3 months, if not conceive within 2 to 3 months, we can discuss to go for the IVF and the outcome will be better.
Right. Dr. Patel, क्या बीपी और थायराइड की प्रॉब्लम की वजह से एग फॉर्मेशन पे कोई इम्पैक्ट पड़ता है क्या?
Yes, definitely. Any problem in body like age, obesity, hypertension, diabetes, thyroid, any infection, any addiction leads to decreased quality of egg and decreased fertility. Again, there is a chance of abortion is also.
Okay, so the overall health of
health of women and health of female partner also affects on fertility and the continuation of pregnancy also.
All right. So first you have to tackle your own health before you start.
Yes, very important, because health is very important. Whatever the negative point before going pregnancy, even young people need some investigation like sonography, like any thyroid problem, like any thalassemia problem, any hemoglobin problem in male, diabetic, thyroid. We have seen many male having lots of problem like addiction, obesity, thyroid problem, diabetic problem, hypertension. So many, and in IT people having under stress. So maybe sedentary life leads to problem in sperm quality. So whatever the before going any pregnancy, better to evaluate it if possible, understand it, correct it, make the healthy atmosphere, then outcome will be better.
All right. Um, Dr. Patel, you were saying that when it comes to a blastocyst transfer, you would like to transfer just one blastocyst during a cycle, provided the uterus conditions, the endometrial lining, etc., is good. But is that the ideal number of blastocysts transferred? Do you sometimes face some suggestions or pressure from the patient to transfer more than one blastocyst? What is the ideal number actually?
Yes, madam. That all depend on the quality of uterus, endometrium, age, and quality of uterus, and which trial. So if it is first trial and young, you having good uterus, good endometrium, so we can counsel the patient. We will transfer only one, and at the same time we counsel couple to what is the probability of pregnancy and what is the advantage, because if single embryo, chances of single pregnancy is more, so we can avoid many problem during pregnancy like prematurity or hypertension or diabetic. But yes, if it is patient under pressure, they need pregnancy in a first trial, and we have to counsel. We will do two embryo transfer, but you have to understand what is the negative point of twin pregnancy, and again we have like a prematurity or hypertension, pregnancy induced hypertension or diabetic. But before we counsel, we assess the capability of the female, whether she is capable or not to carry the twin pregnancy. What is about her uterus? What is about her cervical length? Whether previous history of premature delivery or not. Those who have premature delivery, we cannot do twin transfer. To embryo transfer, because chance of prematurity will be high. Those who have previous history of prematurity and some problem in uterus also, like unicornate uterus, or any the uterus size is less, then we can limit the embryo to prevent prematurity.
To one, the number to one.
Yeah.
All right. We have another question coming in from a Facebook user who's asking, is there any scope for a woman to get pregnant through IVF or IUI at the age of 40 if both fallopian tubes are blocked?
If both tubes are blocked and at the age of 40, normally IUI will not work. Then IVF will be the better option. But we can counsel the patient, we both are blocked and she want to do IUI, then we need to correct by the operative laparoscopy. Before doing IUI, we have to see where it is blocked and what is the cause of the block. If we can correct during laparoscopy, then we can think about the IUI. Otherwise, at this age, with the two block with age 40, IVF is the first choice.
All right. Dr. Patel, another question that we have received from a user is, I'm a 38-year-old woman. I have had 3 miscarriages in the past 4 years. Each time I had conceived naturally. My AMH level is normal. Do I need to opt for IUI or IVF? Now, Dr. Patel, will IUI or IVF really solve this person's problem? Because she is making an embryo and a baby, but she's having a miscarriage. Should she look for solutions, or should she try to investigate why she's having miscarriages?
Right. Because of repeated pregnancy loss, there are so many reasons. So we have to understand what is the reason for the abortion. So maybe genetic, maybe hormones problem, maybe uterus related like anatomical problem, maybe infection, maybe some deficiency, or maybe sometime congenital hypercoagulation. So before going to any further pregnancy, go in detail like karyotyping, 4D sonography, ANA, homocysteine, beta-2 glycoprotein, IgG, IgM, any DNA fragmentation, any problem in husband. So all together we have to thoroughly investigation. If
Okay.
you find any reason, any problem like obesity, infection, any genetic problem, we have to correct it. And depending on the situation, we have to counsel the patient what are the chances to getting again pregnancy and continuation of pregnancy, what is the chance of abortion.
Mhm.
So we have to thoroughly
Investigate.
investigation. Thorough
Okay.
investigation is very important. Do not hurry. Take time. Give 3 to 4 month break before going the next pregnancy. Any problem, correct it depending on the etiology, because depending on the cause, and make the healthy atmosphere. Then again depend on the AMH, ovarian reserve, uterus
Mhm.
quality, endometrium quality, and
Mhm.
patient willing. We can suggest them go for natural cycle, go for IUI, or even IVF. We can
IVF.
suggest
Right. But I
with
would think that this.
PGTA or without PGTA. That is pre-implantation genetic
Mhm. Testing.
assessment.
Right. So I would think that this person is actually lucky. She makes a baby on her own, only she can't keep the baby. So get your investigations done. Perhaps you'll have better luck next time. Now we have a question coming in from Facebook user. I think I'll take this as the last one. The question is: I'm 35. I'm having a little bleeding 10 days after embryo transfer. Is this normal?
Yeah, sometime if it is, we have to see the what is the exact reason. We have to do if it is 10th day of the embryo transfer having spotting. Uh, then if it is 10th day after embryo transfer, we can do sonography, whether it is fresh transfer or frozen embryo transfer. If it is fresh, we have to see the any situation of ovary stimulation. We can do early beta HCG and some blood test. If beta HCG is depending on the beta HCG, that is pregnancy, early pregnancy is not or there, then we can assure them. We can give some progesterone, we can give some hemostatic medicine, we can
Mhm.
reassure, and again we can continue the pregnancy.
Dr. Patel, but it is normal. Usually, some
Now,
women do have spotting.
out of 100, two or three may get this type of problem.
Okay.
Patient having some, if she had not taken properly medicine, or she may have any another cough, cold, or sometime we are giving some coagulant medicine like heparin or
Mm.
ecosprin or L-arginine, then we have to stop it. Some
Okay.
anticoagulant we are using to improve
Okay.
the IVF result. If
Okay.
she bleed before beta HCG, then
Mm.
this anticoagulant like heparin, low molecular heparin or low dose aspirin or any anticoagulant, we have to stop it.
Stop it. All right. I'll take last question then, Dr. Patel. And one Facebook user is asking, what are the treatments available for azuspermia?
Yes. Now everybody wants their own eggs, own sperm, own uterus pregnancy. And there is a lots of development in a case of male infertility. So if we having azuspermia, we have to, if it is first time, first semen analysis, then wait again after 7 to 10 days, you can repeat it and stamp it. It is a pakka case of azuspermia. Then we have to assess whether it is obstructive azuspermia or it is a non-obstructive azuspermia. We have to do serum FSH level, LH level, testosterone level, and we have to do some more investigation. If it is azuspermia, then counsel the patient about the treatment of by surgical correction or by IVF. But because of azuspermia, repeatedly azuspermia, then IVF ICSI will be the better option.
Okay.
So depending on the testicular size, FSH level, we have to counsel what is the chance of getting sperm. If it is obstructive, almost 95 to 99% we are getting sperm and very good result. But those who have non-obstructive azuspermia, high FHS or testis is small, then counsel the patient depending on the your FHS level and testicular size, the probability of getting sperm is maybe 40%, maybe 60%. And then pregnancy we can have with the own sperm in spite of azuspermia.
All right. Thank you so much, Dr. Patel, for joining us today and answering so many questions from the viewers, and of course explaining to us what is a blastocyst transfer and how it improves the outcomes of IVF cycles. Thank you so much for joining us.
Thank you.
So that was Dr. Patel answering all your questions on fertility and IVF treatment. Now, if you have more questions, you can send them to us. And do follow us to stay updated on all that concerns your health and well-being. This program was supported by Bharat Serums and Vaccines under its Public Awareness Initiative. Now, we are going to be taking a short break on Project Start, but we'll be back soon in July with more of these shows to answer your questions, to talk about fertility and how you can improve your chances of starting a family. Do keep sending us your questions, and we'll certainly try to include them in our subsequent shows. And do watch the recordings of our shows. You may find lots of wisdom and insights on how you can naturally improve your own chances of conception, because all the experts who've joined us during the show have given us their nuggets of information, their ideas on what can work best. So do watch the recorded shows to get insights on fertility and problems and how they can be overcome. Now, keep sending us your questions and keep following IHW Council. Till then, stay at home, stay safe, and take care. Goodbye, and see you soon.